Okay, good morning, everyone. We're glad to have you here joining us. My name is Jane Johnson, and I'm the Associate Director at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment to go over the housekeeping rules of the webinar. Please feel free to introduce yourself in the chat and tell us where you're from. If you have any technical issues during the webinar, please put a message in the chat and we will do our best to address you or to address the problem. If you have any questions or comments during the presentation, please feel free to type them in the chat. And you can address each other's questions and comments there as well. At the end of the presentation, we will have time for discussion and questions. And if you want to save your questions or comments for that time, and if you'd like to speak yourself, please raise your hand. That's under the reactions at the bottom of the screen. And we'll unmute your microphone and we ask that you briefly introduce yourself, and please feel free to turn on your camera if you'd like. And when contributing to the discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. Please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. So today is our Let's Talk About OMM Research educational webinar, and it's entitled, What the Heck's a Card Study and What Does It Mean to Me? With Dr. Jack Westfall. John M. Jack Westfall is a family doctor in Washington, D.C. He completed his MD and MPH at the University of Kansas School of Medicine, an internship in hospital medicine in Wichita, Kansas, and his family medicine residency at the University of Colorado Rose Family Medicine Program. After joining the faculty at the University of Colorado Department of Family Medicine, Dr. Westfall started the High Plains Research Network, a geographic, community, and practice-based research network in rural and frontier Colorado. He practiced family medicine in several rural communities, including Lyman, Fort Morgan, and his hometown of Yuma, Colorado. He added medication-assisted treatment to his clinical care in 2016. The work of the HPRN and the CAC has included funding from the CDC, NIH, AHRQ, and numerous state and local foundations. His recent work includes primary care clinical, educational, research, and administrative stints in California and DC, where he continues working to integrate primary care and public health through clinical and policy research. Just personal note, I met Jack at a North American Primary Care Research Group meeting in the early part of this century and was intrigued by his ideas about practice-based research networks and community advisory boards. And as we were forming DO-Touch.NET in 2009, Jack agreed to be a consultant for our grant proposal to the AOA. So why, you might ask, is an MD interested in osteopathic research? And that's because Jack has some serious osteopathic street cred, which I believe he is going to share with us. So please help us welcome Jack Westfall.
Hey there, can somebody give me sharing opportunity, please, so I can share my... There we go. Share, okay.
Sorry about that.
Are you able to see Are you able to see this? What the heck's a card study and what does it mean to me?
You bet.
Awesome. Well, I am so tickled to be here. Jack Westfall. I'm in California today, but I live in Washington, D.C., but my home is really Colorado. I'm sort of the last 5 years, my wife and I have been moved around a little bit, trying to get settled in our penultimate work before retirement. I'm a little intimidated, I have to tell you, because as Jane said, I am not an osteopathic physician. I'm a medical doctor. I went to the University of Kansas. However, I do have a little bit of osteopathic cred. And so I'm going to show you a couple of things of my history. This is Elmer, his student history from 1896. Elmer Westfall was my great grandfather's brother, Elmer. And this is one of the early classes from A.T. Still. And these are the people in the Westfall family who were Kirksville graduates. So Elmer and DeWitt Clinton. DeWitt's my brother. And Thomas, I think, is their brother as well. So I think there were 3 brothers who were there at the time of Andrew Still in the late 1800s, early 1900s. DeWitt was my great-grandfather, and his kids are Eugene Raymond and Kenneth down below in 1921. Kenneth is my great uncle. My grandfather, E.R. Westfall, he went by E.R., actually flunked out. Flunked out of Kirksville, I'm sorry to say. He had measles as a child and his vision was very poor. And when he went, his brother Kenneth was supposed to help him study. And Kenneth was too busy doing his own work that my grandfather couldn't keep up. There were some others during that time period. And then jump forward 60 years, my physician growing up, my family doctor and my brother's best friend was from A.T. Still University, an osteopath, Dr. Bob Jensen. My college buddy from Kansas was a A.T. Still University graduate. He went to A.T. Still. I went to the University of Kansas. My niece is a graduate from A.T. Still University and practices osteopathic medicine at Mankato Family Medicine Residency that's part of the Mayo. So I like to think that there's quite a bit of Westfall, of osteopathy in the Westfall. I'm fascinated that osteopathic colleges had bands and they had a tennis team, they had a baseball team. And I have to say, as I've read and learned about A.T. Still, they included women in the School of Medicine at A.T. Still from the very first year, so I'm always impressed by that and the commitment to equality and equity in healthcare and healthcare education. These are 2 of my uncle's kids, my great uncle's kids, William Royal and Edgar. I will say that William Royal, this one on the lower right, concerns me a little bit because his motto was collect before treatment, which I thought was pretty funny. But here's the class of 1921. My uncle Kenneth is in there. And then this is a telegram from my great-grandfather, D.C., DeWitt Clinton Westfall, to Charles Still on the death of Andrew Still in December of 2017. Profoundest sympathy for you and your brother and sister in the loss of your illustrious father. To have been the child of so good and great a man is a heritage left but to the few. Grateful millions reverently thank God that he ever touched their lives and lived to bless mankind. D.C. Westfall. So I'm very proud of that. I'm tickled to be here. My disclosures are that I'm not an osteopath or an osteopathic physician. I'm an allopathic family doctor researcher. I've practiced for 30 years with MDs and DOs in the practice. I've learned a few low velocity and trigger point maneuvers over the years and have included those in my practice since I was a resident. I'm an eager learner, curious, and ready to listen. However, I'm not quite ready to listen because I was actually asked to give a talk. So I'm not going to listen to you yet. I'm going to talk, and then we'll then I'll be happy to listen down there in a few minutes. So what are the types of research that can be done in primary care practice? Well, observational research, of course, is part and parcel of what we do. We observe things. We can do survey research. I'm going to focus on card studies as a part of survey research, but primary care research can do clinical research, clinical trials, randomized trials, comparative effectiveness trials, patient-centered outcomes research, epidemiology, and population health. And my guess is that for the folks here, and I'm not sure how many people are on board now, it looks like 20. If you've done research with DO-Touch.NET, or have done research with any other groups, you may have participated in any number of these types of research, from what happens in the exam room with this patient to how does this patient fit into the context of their family and their community. Well, so what's a card study? Well, first and foremost, a card study is just a survey. However, it's a little bit more than that. A card study is the method by which we deliver and collect the data from those surveys. There are observational studies that collect patient-level survey at the point of care. They've been used to describe clinical problems, management, phenomenology of primary care and ambulatory care for over 40 years. And actually, maybe for over 100 years. Card studies provide cross-sectional descriptive data, and they are a robust method for describing primary care. The name card study derives from a weekly card introduced by sentinel stations in the Netherlands, and later by the Ambulatory Sentinel Practice Network. It used to be called the Codman card, named for an early 20th century surgeon, Ernest Codman, who was really committed to what was called at the time sort of outcomes, final results. He was very interested in what came of his work. And so he did these cards that kept track of a patient through their episode of care so that he could determine what was their final outcome. Card studies are pocket-sized, historically, were pocket-sized cards, kept them in the white coat. I don't see very many white coats on the call today, but for those of you who are a little older, you may remember we used to wear white coats, and they were designed to be able to be completed in 60 seconds or so, and it allowed clinicians to carry it from room to room and and complete it for eligible patients. Although a card study is essentially just a survey, it's designed to be completed as the patients are seen by the clinician, by those who provide care. So a short history of primary care. I put this up for a couple of reasons. These are a couple of the giants of my life, Larry Green and John Hickner, and really talk about practice-based research and practice-based research networks, of which you are all a part. And DO-Touch Network has a long, robust history before it and continuing through its work as well. So I'm going to back up a second and really think about, why do we even do practice-based research? So this is some work done in the 1960s by Carr White. And Carr White was an iconoclastic physician who studied all of the healthcare in the United States. And he looked at, got all the extant data around who was being seen for care. And he came up with these boxes. For each month in the community, for every 1,000 people, about 750 of them will have an illness or injury. About 250 of them will seek care in a primary care office, ambulatory care. About 10 of them will be hospitalized, and 1 of them will be hospitalized in an academic medical center. Well, as you all know, most of the research gets done down here in this little tiny itsy bitsy box, 1 in 1,000 at the academic tertiary medical care center. What practice-based research networks allow is for the research to go out where most of the good stuff happens, where you're practicing, where we're practicing, out to the folks who maybe didn't even seek care, but we know that they may have had an illness or injury, or gosh, wouldn't it be cool to study the people who don't get sick? So ambulatory practice-based research in communities can really move beyond that little tiny academic medical center and move the research out into the community. And card studies are one of the ways to do that. So here's a couple of card studies that have been have changed healthcare. And we think of a little survey in primary care, how much impact could it have? Well, over the years, card studies have had a big impact on how healthcare is provided in the United States. The one on the upper left-hand corner. When I was in training, a woman who was pregnant, who was having a miscarriage, spontaneous miscarriage, always got a D&C. That was the standard of care that I was taught in medical school in the 80s. And a few family doctors said, well, I'm not sure if that's not what we always do. We don't always do a D&C for everybody. Sometimes we do a wait and watch. So this early ambulatory sentinel practice network did this card study, and they asked docs, every time you have a patient with a miscarriage, fill out this card. And I'll show you a picture of what they filled out. It gets a little bit of data, tells a little bit about the patient and the outcome. When they published this in 1988, within 2 years, a wait and watch approach became the standard, because what they found was that 50 to 60% of patients with a miscarriage in family medicine had a wait and watch approach, and they had good outcomes. There were no ill outcomes. There were no deaths. There were no hospitalizations for late complications. And so they really discovered that in primary care practices, out in the community, out away from that university, that little tiny box, what actually could occur. And it dramatically changed. And so now a D&C would be a rare event for somebody having a first trimester miscarriage. Likewise, they looked at headaches. And at the time, there was a guideline that recommended a new onset headache in an adult should have a CT scan. And so they said, a lot of family doctors were like, well, we don't do that, even if it is a first time, unless it's, there are some indications. And so they did a card study and looked at what do you do for a first time headache and what are the outcomes? And again, they found that a lot of clinicians out in primary care practice didn't do a CT scan. They may follow the patient. They waited and watched. They did something else. They treated, they came back. And when they published this, it changed the guideline to include much more stringent recommendations for when would a CT scan be helpful. They confirmed that their cards that they were doing were accurate with office-based chart abstraction, so that they could really say, hey, the cards that we're collecting, the data, these surveys, this card study is collecting accurate data. Here's what an old card looked like. This is from Aspen, the Ambulatory Sentinel Practice Network. I think it's pretty funny that if you look at the date, it's 1980 something. They weren't even, these were pretty early, and you would put the patient's name here on the left. This would get torn off before it was submitted, and then you would return this each week. with how many people who had all women you diagnosed having pelvic inflammatory disease or spontaneous abortion, miscarriage. Well, we've continued to do these, and this is the cool thing about card studies is that they have a low burden on an individual clinician. As practice-based research network, the really nice part of it is that you can gather a lot of data with less work from an individual clinician and more generalizability across practices. So here was a project we did on missing clinical information during primary care visits. We ask, how often do you, for this patient you're seeing right now, do you know that there's data that exists somewhere, but you don't have access to it? A CT scan, a lab result, a hospital discharge. You know the data exists, you know that information exists, but you don't have access to it. We did this in 32 primary care clinics, 253 clinicians, and each of them just worked for a half a day doing this survey. They filled out this survey, this card study, for every patient they saw in a half day. So it varied from 5 to 15. And we had those 253 clinicians delivered 1,600 patient encounters. And as you can imagine, about a third of about 15 to 20% of the time, there was missing information at the point of care. And clinicians spent an average of 30 to 40 minutes trying to find that information, and oftentimes had to redo it. So they had to reorder the CAT scan, they had to reorder the blood test because they couldn't get the information and they really needed it in a timely manner. We published a little methodology. I think this is why I got invited here today, because we published sort of the methods for how to do this a few years ago, 10 years ago, and we've continued to do card studies. However, I will say that card studies were very common in the 80s and 90s. And then we got these things called electronic health records. And, you know, some of you may have implemented an electronic health record. You may have heard of them in your practice. And, you know, most practices now have them. And there was always a promise that, oh, electronic health records will give you all the data you could ever want for your practice and your patients. And so card studies, oh, you don't need those card studies because your EHR is going to be able to do this. Well, has that worked out for folks? And I encourage you to put in the chat whether you think your EHR is able to deliver the data you need on your patients. In my practice, it didn't. And so over the last 3 to 5 years, we've seen a resurgence of card studies as a data collection tool and a survey to gather information that can't be gleaned from an electronic health record. Card study is a method. Card studies are completed by practices. Oftentimes, depending on the question, you might spend a half day or a full day. You might take a month because it may be something that you want 10 patients. You want to have 10 encounters of patients with a headache. Or you might say, hey, I want to hear what the prevalence of a condition is and ask something about every patient you see for a half day. The goal is to have minimal practice burden, minimal clinician burden, with the benefit of hundreds of patients collected by dozens or more clinicians. Typically, the clinician completes the survey, the card study at the time of the visit. However, the variations can occur. And sometimes what we found now is that people wait till the end of the day, and when they're charting, they may fill out the cards on each patient as they chart. What kind of questions can you ask in a card study? All sorts. I love prevalence studies. This is, you know, what we call a denominator study, so that you can determine what's the prevalence of a condition. So you may say, we're going to ask you to fill out this survey for every patient you see. And I'll give you an example of one later in a few minutes. It may be that you want to study a specific condition, and that would be a numerator study. So please fill out this card for every patient you see who has low back pain, headache, GI problems. Sometimes there are inclusion-exclusion criteria that help make determinations. And then we really try to make sure that this survey can be completed in a minute or two. It says a minute or less. I think I would say a minute or two. However, what that means is if we're doing a denominator study and you're going to spend a half day doing this or even a full day, the amount of time that you spend on this is anywhere from 20 to 30 minutes. And yet your data combined with all the other folks' data who are doing this, we can get 1,000 patient surveys, cards done, and you only had to spend 30 or 40 minutes over a 2-week period doing it. So here's some more studies. What factors influence change in type 2 diabetes treatment? We had 483 cards. What factors influence change in blood pressure? This was a study on clinical inertia, both of these, and sort of what are the factors that primary care clinicians use to make changes. Oftentimes, primary care clinicians are rated lower than specialists in terms of diabetes care or hypertension care, but that forgets all of the other confounding that primary care take care of, because they have to manage all the conditions: hypertension, asthma, COPD, heart failure. There's a couple others you can see, down to very specifics. What are the presenting features of acanthosis nigricans? That was an interesting study to look at a sign that can be pre-sign for diabetes. And so we were looking at how do people present with features of acanthosis nigricans? What is the impact of patient medication requests on the clinical encounter? This was at the height of the direct-to-consumer advertising of drugs. And so we wanted to know, what was the impact? Did it take extra time? Did clinicians like it? How often did it happen? And this was a denominator study to see how often does a patient ask about a drug. And you all have faced that, I'm sure. So you can see a whole host of different types of questions. And I want to just pull your eyes to the right column, that we're able to collect with a card study 1,600 patient encounters, 500 patient encounters, 800 patient encounters, 1,000 patient encounters, 2,700 patient encounters, with a small amount of work by each clinician and each practice. Card studies take about a year to 2 to complete, from the study idea to the publication. So these aren't 3 to 5 year long clinical trials. These can be done pretty quickly. From idea to publication can be done in a year or 2. They take about $10,000 to $25,000, so they're not free. They do require a little bit of analysis time and, being in the practice and teaching the practice and teaching the clinicians how to complete these. They're anonymous, so they typically don't collect any PHI. They're low risk, so IRBs are pretty easy to use these. These are essentially de-identified survey data. Okay, card studies have been used for 40 years. You've seen a bunch of them. You've seen some ideas. They provide observations, data, and actions. They're low burden for an individual clinician and practice. They're not no burden, but they're low burden. And they're a robust method for describing ambulatory care. Well, what about OMM? Are they a possibility for doing osteopathic manipulative medicine? I would say yes. I would say these are this is a method that can ask questions about the incidence of condition that you treat, the prevalence of a particular maneuver that you use for the treatment. What are all the various treatments that people around the country or within the PBRN use for a specific condition? So headache or neck pain or back pain. What are the host of what's the variation between practices? What's the choice of OMT for a particular condition? These are, again, some more specifics. How often do you use OMM in your practice? Are you getting paid for it? Who's reimbursing? And how do you incorporate it as part of a diverse primary care practice? What's the equipment needed for setting up OMM in your practice? Space, equipment, personnel. How do you manage this in a practice? That might be questions that are great for residents, trainees, people thinking about adding this to their practice. Comparative effectiveness. PCORI, the Patient-Centered Outcomes Research Institute in the United States, has lots of funding for comparative effectiveness. So how do we think about comparative effectiveness research within osteopathic manipulative medicine? Where does OMM fit into prevention or chronic disease management? Or adding or mixing with other types of treatment for holistic practices that have a host of different providers, whether those are primary care, behavioral health, allopathic or osteopathic clinicians. How do you mix in OMM to other types of treatment and management? And then what are the other types of primary care questions from an osteopath? An osteopathic physician? What are the other clinical questions? What about community health? How do you structure a practice? These are other types of questions that can come up in a primary care ambulatory practice. Here's one I was just off the cuff. I threw this one out. Understanding the practice of OMM among osteopaths. I've worked with Rocky Vista Osteopathic Medical School and was on their board of advisors for a number of years. I was on the OptiWest advisory for a number of years, and this is one that you could do as a prevalence study. Complete this survey for every patient you see in a half day. Did today's visit include OMM? Yes or no? If no, you're done with the survey. Boom, done with it. If yes, did you bill for it? What was the OMM-based diagnosis? And you could actually insert a drop-down list of the top 10 that you might use. What OMM did you do? Have a set of answers that you could either pick or you could leave it open-ended. And how many additional visits do you anticipate may be required to complete the course of treatment? Maybe done, maybe more. It's just one possibility. And you know what? You all may know the answer to this question. I'm going to beg ignorance because I'm not an osteopathic physician, so I don't know the answer to this. I would be very curious about this one, especially as our training and our practices are much more integrated with osteopathic physicians and allopathic physicians practicing together. How does that all fit together? So you can talk about the prevalence, the diagnosis, the treatments. Where do we go from here? Well, Jane, I put this in. Where do we go from here? You go to Colorado Springs. My gosh, I hope you're all coming to Colorado Springs because we're going to do this workshop again, except it's going to be long. And we're going to actually start doing a lot of brainstorming around what are the questions? What comes up in your practice? What are the things that happen? What are you curious about? What works? What doesn't work? How might you teach this better? How might you identify patients better? So come to the annual meeting in March, and we're going to have a lot of fun. I'll be there. And we're going to do more of this related to card studies for the DO-Touch.NET. You can go to thecardstudy.com, look a little bit more about card studies and a new smartphone app, which we will also learn about in March. This is the teaser to learn about the smartphone app. You know, you can't just do stuff on paper anymore because that's not green. So now we have there's an app for that. And there's an app for card studies called thecardstudy.com. You can take a look there. I am going to stop sharing, and I'm going to I'm going to listen. I don't know if I'll listen, but I'm going to try to listen and look forward to hearing what you all have to say.
Thanks. Just a couple reminders as we open up the discussion. Just if you want to speak, just raise your hand. It's under the reactions down at the bottom of your screen, and we'll ask that you briefly introduce yourselves and turn on your camera if you want to. Please limit your microphone time to 3 minutes to allow for everyone who wants to participate in the discussion. We do have a timer available. If you look at G's screen, and after everyone has had the opportunity to make comments or ask questions, there may be additional time. If you would prefer to read to type in your comment, one of the moderators would be happy to read it for you. And please feel free to ask to answer each other's question. And please, once again, keep in mind that the webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. And so I will start with Hallie has a question. Whatever became of the paper worksheets chart notes from, well, Jack, I don't know that you'll be able to answer this question, from AAO circa 2002 to 2006, was data ever generated into a database of OMT, etc.?
Having been active in the LBORC, my understanding is that nothing did come out of that work.
Okay, thank you. I see Amy Dean has her hand raised.
Hi, everybody. I just had a couple questions. One, I just wondered how involved the statistical analysis is. Like, do you need outside help, or is that something a clinician is capable of? And the other question I think is just, I do OMM in the hospital, so I'm trying to think of ideas to bring to Colorado Springs to study. And I don't know if like somatic dysfunction in acute renal failure or heart failure, if those are the kinds of things that would be appropriate, or if you've done any hospital-based card studies, since that was some of your background as well.
Oh my gosh, Amy, that is just a fabulous question. One of the cool things about card studies is they can be essentially at the clinician level. So it could be that you do a card study regardless of where you are physically. So, hey, and one of the questions might be, where are you doing this? So for, you might say the first question would be, did this patient have OMM? And you may do this for a day or a week. OMM, yes, no. Yes, what facility are you in? And the next, that could be, oh, I'm in an ambulatory primary care practice. Oh, I'm in a specialty practice. Oh, I'm at the hospital. Oh, I'm doing a home visit. And then you could ask additional questions. So the card study methodology is very flexible to allow for the site of practice. It doesn't have to be within a primary care. Most are done within the primary care setting, but it could certainly be done as one of the questions. And where are you delivering this care? So possible. And so, yeah, I think bringing those questions would be very cool. The first part of that question, what was it?
Oh, is it statistical analysis? How you need outside help, or
yeah, so typically the most sophisticated is well, you do frequencies and your table one, who are the practices, who are the clinicians, and then some descriptors about the patients, age, gender, race, disease, stuff like that. Sometimes then you do crosstabs. So, hey, physicians who were trained before 1990 behaved this way. Physicians who were trained after 1990 behaved this way. That might be a way to break that down. And those would be crosstabs. You know, one of the cool things about being part of DO-Touch.NET is that the individual clinicians really don't have to worry about doing the statistical analysis, because this is what being part of the network does. And the team at the home office, Jane, Brian, G, and now somebody new named Corey, will help with, and they will do those analyses for the team. I'm up.
Great, thank you.
I will. We haven't introduced Corey yet because he hasn't officially started yet, but a sneak preview, Corey Lubering will be starting on Wednesday as our new PBRN coordinator. So we're glad to have him with us today, and really glad he's joining us on Wednesday. Okay, next up, Sergio, I believe you said you wanted to ask a question or make a comment.
We cannot hear you. No, we cannot hear you.
You are unmuted, so it must be something to do with your microphone. Nope. Nope, we can see you talking. Okay, maybe Sergio, we'll come back to you. You can keep trying to get your microphone working. I think our next comment was from Jed. And he was asking a general question here about, of those assembled, I assume, here on the call, on the webinar, how many are in primary care and how many focus on OMM? It affects the type of questions asked. So maybe here, I'll set up a quick poll and you all can answer that. How's that sound?
It sounds like a question for a card study.
Yeah, there we go. So Brian.
Yeah, so I was just thinking, just because of our international members, one of our challenges is dealing with formats that are easily translatable and managed across different languages. It would seem like card studies might be ideal for that. Have you had any experience of doing a multilingual study within this system?
Oh my gosh. So the short answer is no. The longer answer is that historically, Aspen did collaborate with the Netherlands on a number of card studies, and so they were in multiple languages. There's a step 2 higher level type of card study that you can actually do to link patient experience as well. That's not what we're not gonna spend any time doing that yet. That's the advanced lecture. And when we've done that, we have included at least Spanish language for that. In the United States, clinicians by and large practice in one language, and so that's historically what we've spent the most time doing. I think the the surveys, because they are brief, could be readily translated into other languages for clinicians and practices and systems in other places around the world. And the nice thing there would be that if the survey questions are all essentially the same, you could do nice comparisons between countries, or at least between languages and respondents. So I think it's certainly possible.
One follow-up question to that. So certainly a major issue is looking at factors with healthcare disparities. Have you found that this approach has been more easily implemented in areas where performing research may be more seen as more controversial?
Absolutely. Actually, Brian, you know, one of the things that we've found is that, you know, clinicians are really busy, and so they don't have time to consent patients and do randomized controlled trials, and oftentimes. And so we try to really get out into the practices that represent or are examples of sort of real life clinical care out in the communities. And so we've used federally qualified community health centers and community health centers with that address low income people. Oftentimes we will do a baseline survey of the practices to gain information about who's seen in this practice, who are the clinicians, what's the practice, what's the geography, what's the payer type, what's the mix of types of patients and languages and cultures and community and things, so that we can then really talk about how do people practice in various types of communities.
Thank you.
Thanks. Okay, I'm just going to launch this poll, and you can answer it while Hallie asks or makes her comment or asks her question.
Thank you all. So I am, as one of the people who was part of the LBORC subcommittee for the database development, it was a worthy goal that had 3 really good worksheets that used to be on the AAO website under the research tab. Would it be possible for us to ask to borrow them from the Academy in order to see if they would be useful? Because there was one for cranial, there was one for general intake, and then there was a really good follow-up form that was only 2 pages. That was really easy with a grid for being able to enter, say, upper versus lower thoracic and severity of findings and responses. Very easy and concise grid. And it would be useful for us to consider an adaptation to card study using data sets that already had been worked through by Sandra Slazinski and other osteopathic physicians who were members at the time of this kind of work group. We don't need to reinvent the wheel. Let's start with what we already have put into use. I used it for years as my practice note before EHR became the prevailing approach.
So I can't say I know what the Academy has maintained in regards to the efforts that were done at that time. I know it was all pen and paper, and so that certainly has limitation. I can say that DO-Touch.NET did take from that project and constructed our system of collecting physical exam findings per regions within the TART mnemonic types of techniques, systematic dysfunction, severity, so on and so forth. So all of that, which we have and maintain and continue to use in our work, does come from that era of the LBORC's work. As far as the hospital and the newborn components, that we have not had any studies So at this point in time, I can't comment on where that information might be.
Okay.
So Jane, I'm taking a look at the survey results, and it looks like the vast majority are OMM focused. And I just point out the card study methodology is really type of practice agnostic. It's a research methodology. It's not a clinical specialty or a clinical, there's not a requirement. My experience has just been in primary care practices because that's where I've spent the last 25 years. But OMM focused practices could easily do the card study methodology to ask and answer questions that they're interested in.
Great. Thank you.
And I look forward to March to actually thinking about what those questions might be.
Yeah, I believe that many of a large majority of our members, well, at least a majority of our members are OMM focused, but as Bill Brooks put in the chat, general medicine issues arise given the time he spends with patients.
Yeah.
And so,
and there will still be lots of questions about what's the variation of OMM between clinicians for particular diagnoses, and the types of treatments and the types of management that is done. So I think I'm excited to think about and hear about in March, what are those clinical questions that come up?
we're excited too. So, unfortunately, our live discussion time is up. So don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, and we can continue discussion there, in the comments and stuff. Watch your email for when the recording is available. Thank you, Jack, for sharing this information with us, and we look forward to having you help us during the annual meeting to come up with questions that can be added to our DO-Touch.NET research profile. And so I encourage everyone in the chat here. I'm putting the registration link, and it's also in your email for the annual meeting. Yes, Kate says you're definitely part of the DO family.
Thank you, Kate.
So the annual meeting is both on site in Colorado Springs prior to the AAO convocation, and it's virtually via Zoom. So please check your email for the registration information. If you want to learn about the upcoming DO-Touch.NET research project on the role of OMT in the management of post-COVID-19 symptoms, check your email for an invitation to the upcoming informational webinar on February 16th. I see Brian has his hand up.
Yeah, so once again, thank you so much, Jack, for joining us today and helping us begin this journey. I would like to just, my staff is not aware of this, so I apologize. But I want you, for those that are here, and we will disseminate this broadly, that I think we're going to have a special award at our annual meeting for the person that comes up with the best question. And Jack has assured us that we should be able to come up with several that would allow us to be able to, move several studies through the network on an annual basis. So I'm holding him accountable to that. But I'm also, as I said, we will provide some awards for some of the best questions. So start thinking about them, and start thinking about what information, what data pieces that you'd need to answer those questions. That's going to be exactly where we're going to go in our group projects as part of this annual meeting. So we are really looking forward to having you all there. Certainly talk to your colleagues, direct them to the recording of this so that they can get some background perspectives as well. And we're ready to jump in to do business at our annual meeting. So thank you, Jane.
Surprise.
No surprise.
All right. Thank you. So our next episode of Let's Talk About OMM Research will be one of our journal clubs. And it will be on March 24th. So not our usual third Friday. We changed the date due to a conflict with the AAO convocation. So we hope to see you then. So thank you.